Welcome to the APSA Quality and Safety session, where we are highlighting abstracts selected as finalists for the annual Quality, Safety, and Value in Surgery Award. My name is Mehul Raval, and I'm the current chair of the Quality and Safety Committee. And I will serve as moderator for this session alongside committee member Derek Wakeman. This award is given out each year at the APSA annual meeting to support efforts that promote high-value surgical care, with an emphasis on improving outcomes while at the same time reducing resource utilization. Over the past several years, we have seen the number of abstracts and scientific presentations that address topics in quality improvement, patient safety, and value-based care steadily increase. To support the dissemination of these efforts, the Quality and Safety Committee has created a toolkits website where the actual protocols being used to implement these projects are available to all APSA members. These tools include order sets, care pathways, and other critical information that can be tremendously helpful. There are folders on dozens of topic areas available, and I encourage all of our members to visit the toolkit website to learn more. I will now turn it over to Dr. Wakeman to provide a brief background on the methodology for choosing the two finalists for the Quality Award.
Thanks, Mehul. This year, we started with a pool of about 100 abstracts that were eligible for the Quality Award. A subcommittee narrowed the pool down to 20 abstracts that best exemplified quality improvement methodology. Our larger committee of about 25 pediatric surgeons scored these abstracts, and we chose our top 8 to be eligible for this year's Quality Award. All 8 presenters submitted a manuscript from which the best 2 manuscripts were chosen as finalists based on the quality of their improvement methodology and the potential impact of the work on our field. We are about to hear 2 outstanding quality improvement projects which demonstrate improved outcomes and value in children's surgery. Both projects are widely generalizable, and the authors have kindly uploaded content to the APSA Quality and Safety Toolkit to ease implementation at other centers. Dr. Raval will now introduce the first presentation.
The first presentation we will hear is a cost-effective and safe quality improvement initiative for pediatric intussusception by Dr. Arshad at the University of Texas at Houston.
Hi, I'm Syed Arshad, and I'll be presenting a cost-effective and safe quality improvement initiative for pediatric intussusception. We have no disclosures. Pediatric ileocolic intussusception is most often treated with radiographic guided enema reduction, with surgical intervention necessary if enema reduction is not successful. For patients who can be managed non-operatively, there are no definitive guidelines on the ideal length of observation following reduction. We therefore implemented a quality improvement initiative with a protocol to safely reduce post-reduction monitoring, allowing early discharge after successful reduction. Here's our intussusception management protocol developed with stakeholders at our institution, including emergency medicine, radiology, and pediatric surgery. And highlighted is the portion of the QI protocol relevant to this study. As we zoom in, you can see that after successful reduction, patients are observed for 4 hours to ensure resolution of symptoms and toleration of an oral diet. If patients meet criteria and family is deemed to be reliable and with resources to be able to monitor their child and return to the emergency department as needed, patients are then discharged. We hypothesized that implementation of this QI protocol decreased hospital length of stay, decreased hospital cost, without significant change in recurrence rates. We performed a retrospective cohort study of pediatric patients with first-time diagnosis of ileocolic intussusception who underwent successful enema reduction. The QI protocol was implemented in September of 2017, and pre- and post-QI outcomes were compared for index encounters and any encounter within 24 hours of discharge, as this was the average time of observation pre-initiative. Outcomes included length of stay, hospital costs, and rate of re-evaluation and recurrence. An economic evaluation was performed with total hospital costs, inflation adjusted to 2020 United States dollars, utilizing the Consumer Price Index for medical care from the United States Bureau of Labor Statistics. Cost difference between groups were assessed using multivariable regression, adjusting for Medicaid and transfer status. Of 90 patients included in the study, 37 were pre-QI and 53 were post-QI. Patients were similar by age, sex, race, insurance, and transfer status. For length of stay, we found that pre-QI patients had a median of 23.4 hours, while post-QI patients had a median of 9.3 hours. and this is presented graphically in the run chart with the length of stay on the y-axis and month of presentation on the x-axis. As expected, as length of stay decreased, so did hospital costs. Mean total costs per patient were $3,231 in the pre-QI group and $1,861 in the post-QI group. And this is again presented graphically in the run chart with the mean total hospital costs on the y-axis and the month of presentation on the x-axis. This represents a mean absolute cost difference of $1,370 less per patient in the post-QI group. On comparing groups, we found that pre- and post-QI patients had a similar rate of additional encounters, that being representations to the hospital, and a similar rate of intussusception recurrence. In conclusion, implementation of a quality improvement initiative for treatment of pediatric intussusception reduced hospital length of stay, reduced hospital costs, with no increase in post-discharge encounters or recurrence rates. Similar protocols can easily be adopted at other institutions. Thank you for the opportunity to share our work.
Thank you, Dr. Arshad, for your clear and detailed presentation. While the concept of discharge home after successful intussusception reduction has been reported before, your presentation highlights many of the key decision points that must be considered when implementing this change in practice. I commend you on the use of control charts that clearly demonstrate the changes in length of stay and costs over time. I also commend you for collecting data surrounding cost savings incurred during this project. These types of data help us as surgeons gain support from our administrators and leaders for quality improvement efforts. My first question relates to the cost savings you described. Can you share some of the details surrounding your methodology? Were these figures dollars saved by the patient or the hospital, or was it rather differences in charges or payments?
Thank you, Dr. Raval, for the kind comments. In regard to your questions, the total hospital costs were obtained from our hospital accounting system and utilized for our economic analysis. This is the cost to the hospital. Total hospital costs included both direct and indirect costs. Direct costs being costs which can be attributed to a single patient, such as a cost of a medication the patient received, and indirect costs being costs which cannot be attributed to a single patient, such as a portion of the electricity bill. The costs were then adjusted for inflation, and cost difference between the pre- and post-QI groups were assessed using a generalized linear model adjusting for Medicaid and transfer status.
My next question addresses changes that you observed over time during implementation of your protocol. I was involved in a similar project several years ago, and initially the number of faculty interested in participating were few and the observation times were long, on the order of 6 to 8 hours. As we became used to the protocol, the number of faculty participating increased and the observation periods shortened. I wonder if you had a similar experience.
Fortunately, we did not have this issue with our intervention. In the pre-implementation period, we had buy-in from all pediatric, surgical, and emergency medicine staff and care teams. Therefore, once our intervention went live, it was well followed. In the pre-implementation discussion period with stakeholders, there was concern from our emergency medicine faculty that increased time in the ER prior to discharge would create patient flow issues. However, although there was a slight increase in time in the ER prior to discharge, there were no issues with patient care or patient flow. Thank you.
The second presentation is reduction of postoperative opioid use in neonates following congenital diaphragmatic hernia repairs, a quality improvement initiative by Dr. Grabsky from the University of Virginia.
Thank you for the opportunity to present our work. We have nothing to disclose. There's growing evidence that neonates treated with high doses of opiates may have diminished neurodevelopmental scores as well as social sequelae in early childhood, which is gaining national attention. Additionally, opiate administration can have negative clinical effects, including respiratory suppression and delayed bowel motility. We implemented a multimodal intervention to reduce opiate use in neonates undergoing surgery in our NICU. Following multiple stakeholders meetings between our pediatric surgery, pediatric anesthesia, and NICU practitioner teams, we agreed on an opiate reduction strategy, which included standing intravenous acetaminophen administered every 6 hours for 48 hours postoperatively, a series of post-surgical pain education seminars for NICU providers, and the inclusion of a pain control huddle for each patient at post-surgical sign-out with the NICU team. We first demonstrated the effectiveness of this intervention on non-emergent gastrointestinal surgery, but also wanted to evaluate its efficacy on complex surgical patients requiring prolonged NICU courses, such as patients born with CDH. Our investigation included all children who underwent an open CDH repair while admitted in our NICU. All ages and comorbidities were included. We used a historical control group to compare the effect of our intervention on postoperative opiate reduction and neonatal pain and agitation scores, which were our primary outcomes. Secondary outcomes included clinical safety profile and relevant clinical outcomes such as postoperative intubation time period, TPN length, and postoperative length of stay. This table represents the preoperative and operative CDH-specific characteristics of the 3 cohorts in our study. The pre-intervention group, which included 18 patients, the intervention rollout group, which included 6 patients, and the post-intervention group, which included 21 patients. There were no statistical differences in nitric oxide dependency, shunting across the PDA, liver in the chest, or the use of Gore-Tex mesh repair at time of repair. We used process control charts to note time trends and our primary outcomes with respect to our intervention. Postoperative morphine equivalents for each patient is noted on the y-axis. Time from the beginning of our study in January of 2011 to the end of our study in December of 2020 is noted on the x-axis. The blue box represents our intervention rollout period. There's a clear reduction in both the total amount and variability in postoperative opiates associated with our intervention. When calculated as a before and after manner, our intervention reduced postoperative opiates by 97%, which was statistically significant. This is a process control chart of our median neonatal pain scores from 0 to 48 hours postoperatively, which is represented on the y-axis. Time is on the x-axis with our intervention period again represented by the blue box. As demonstrated by the graph, there was no change in NPAS scores across our study. This was corroborated on a before and after analysis, which noted no statistical difference between groups. Lastly, this is a box plot of our postoperative intubation length by intervention group. Postoperative intubation hours is on the y-axis. Our pre-intervention group, intervention rollout group, and post-intervention group are noted on the x-axis. Our intervention was associated with an approximately 100-hour reduction in postoperative intubation length, which was significant. I would like to thank my co-investigators, specifically Jeff Gander, who is the senior investigator on this project. Please contact me with any questions regarding this work. I'm happy to discuss key aspects of the intervention, including practical steps when we rolled out this intervention in our NICU. Thank you once again for the opportunity to present our data, and I look forward to questions in the discussion to come.
Thank you for this outstanding presentation, demonstrating the feasibility of markedly reducing opioids in neonates after congenital diaphragmatic hernia repair. The authors utilize rigorous quality improvement methodology by tracking their outcome measure, postoperative morphine equivalents, on a control chart. Further, they demonstrate that their process measure, neonatal pain scores, was not affected by the intervention. Importantly, they also found that total time on a ventilator postoperatively was reduced significantly after their intervention. I think many of us can appreciate that children with congenital diaphragmatic hernia can often end up on large doses of opioids and sedatives and even become habituated to these medications over time. This paper nicely shows that reducing at least the opioid component is feasible, safe, and generalizable. Can you comment on your institution's general sedation plan for neonates with congenital diaphragmatic hernia? We are particularly interested in what these children receive before diaphragmatic hernia repair.
Thank you for the question, Dr. Wakeman. In general, following intubation of neonates with CDH, we do not immediately start aggressive sedation at our institution. We use intermittent pain control and routine suctioning of the endotracheal tube. We do have a low threshold for starting dexmedetomidine in our patients, and if these measures are ineffective, then we will add a fentanyl drip. Though it was not directly part of our quality improvement initiative, we have seen a spillover effect in our neonatal population, and qualitatively, the care team has been using less opiates preoperatively as well as postoperatively.
Thank you. What advice would you give to a provider who wants to start an opioid reduction quality improvement project in their own neonatal intensive care unit?
Thank you again for the excellent question. I think one of the key aspects that made our QI project successful was aligning all the critical stakeholders at the very beginning of our project. At our institution, this specifically included multiple meetings with our NICU LIPs, our NICU nursing team, as well as the pediatric anesthesia group and the pharmacy group. This created buy-in from all the people that were interacting with our patients every day. I would also highlight that our QI project took a full year to roll out. We had a multimodal approach to our intervention, and these phases were implemented at slightly different time periods. So patience was critical, and then having a multi-year perspective was also key.
Thank you both for your wonderful presentations that showcase how we, as pediatric surgeons, are moving the field to more efficient and safe practices. Once again, I encourage our membership to visit the APSA Quality and Safety Toolkit to learn more about these and many other projects that are showcased. The award winner will be announced at the APSA award ceremony presentation on October 27th of this year. Thank you all once again for participating in this session.
What a great two presentations. I'll tell you, I think it's really important to get stakeholder buy-in, especially in the NICU. And for example, I did a CDH repair thoracoscopically yesterday, and I went up and talked to the attending, talked to the nursing staff, told them, I don't think we need narcotics here. We did rib blocks. It was thoracoscopic. I came in this morning, the kid's on epi drip because he's on a Dex and morphine drip, despite everyone I talked to and how we weren't going to do that. So I think getting stakeholder buy-in is key, and that was a great addition, something that I'm going to make sure we do in our future studies.
I think we learned that from a lot of the protocol-driven work coming out in the last decade or so. I think of ERAS as the same thing, and learning how to work with the anesthesia team and ICU teams and limiting fluid intake and narcotics, etc. You can't drive this as a sole surgeon. It is a huge team effort and an educational effort. I think to get a project like this or to make change is not easy.
Yeah, I think that goes back to the small bowel obstruction contrast study. It's you have to get buy-in the radiologists, you have to get buy-in the emergency room providers, and I think these preliminary studies, which one demonstrates safety, can help then get the stakeholders to buy into what we're doing and come along with us.
Yeah, absolutely. I completely agree. I think having all of these departments involved, and we're really lucky we have a pain team that's really involved as well. And that's, I think, really helped to bring down the opioid requirements for these patients. But I think more studies like this are really going to help drive that forward with all the different departments that are going to get involved.
Yeah, this has definitely been a change in culture, in government. We're all in different states, but I get an email every day of every narcotic prescription, which now is so few, almost nil, compared to what we were doing a decade ago. And I think this has made medicine better, and it has certainly helped our patients.
Yeah, I think we were hurt by that fifth vital sign as pain many years ago. And some of our metrics of how good we were as physicians was tied to our pain control. And I think now the focus has changed, and really parents are more willing to get on the bandwagon of just using non-narcotic analgesics.
Yeah, I completely agree. And having the bedside nurses, I think, on board too is one of the strongest things you can do to move this forward, because they're kind of the ones that are assessing that and reassuring the parents, reassuring the patients when they're old enough.
And expectations, right? I think setting expectations in preoperative counseling is helpful too. And setting expectations about getting out of bed and patients you've done laparotomies on, and knowing what each day is expected from the patient and the families, I think is helpful for them to overcome the fear of the pain that is associated, obviously, with our profession. And so I think setting the expectations early, and I'd say they're going to be out of bed the first day and in the chair and go for a walk by the next evening, and et cetera, I think sets those expectations, along with what the pain management plan should look like during that time.
How about switching to the pediatric intussusception study and discharging patients at 4 hours, showing it's safe, it's significant cost savings. Do you guys do that at your institutions? Is 4 hours the right number?
At Cincinnati, we have that fast track protocol, which those patients get this study done as long as it's reduced and confirmed. They stay in the emergency department for 4 to 6 hours of feeding trial, and they're discharged home during that time frame. So, and it's been very successful. That was one of those tests of change that has worked really well, got buy-in from all participants, and has really made a change in, like demonstrated in the talk earlier, cost to the hospital. And I think that was one of Dr. Powell's questions earlier in the initial segment. And someone maybe won a prize or a free trip to, I don't know. I think Dave should give a free trip to San Diego next year. That should be one of the prizes. We'll have to talk to him about that.
Absolutely. We do the same thing. We have a kind of a expedited protocol where patients can be discharged from the ED, and talking about expectations too. We'll even explain that protocol to parents before they go for a radiologic study to see if they can get reduced with an enema, so that they understand kind of what the next steps are going to be. And they're not surprised afterwards saying, all right, great, now we're just going to feed your baby and have you guys go home. And having that talk with them beforehand about what they should look for to come back to the hospital if they need to. And then going through the whole process, everyone's on the same page. And I think the parents are happy to go home too. I don't think that they want to stay in the hospital overnight if they have to. So.
How about if I sprinkle a little controversy in here? What about as we as surgeons do research that lowers hospital costs? So I'm thinking a non-operative API study, this study. What about shared faith? So if there's a reduction in cost, should the surgeons, not personally, but their divisions, get some of that monetary money, maybe for research, maybe to use in other endeavors, or should the hospital just benefit?
Wow, you want me to have to, anyone have a job out there? Because I'm going to start to speak up soon and I need to go somewhere in the next few months. So thanks for bringing that up. I think when I look at costs and surgeon, you're bringing up a very sensitive topic, surgeon remuneration. I think different institutions have different models. And so it really depends on the hospital model, how that can contribute to the surgeon. I agree with you, and I think everyone probably on this meeting would agree. We should benefit it in some way. In our salary, I don't know, but it enhance research endeavors, improve more nursing help in the office, whatever that might be. And I know we get a lot of help from the institution, so giving back is part of that. It is definitely a symbiotic relationship that sometimes gets out of balance sometimes, but I think demonstrating the cost savings can be helpful.
I think that's a perfect answer. On that, maybe we'll make the transition over to the next session. So next, as you all know, it's really expensive to run these meetings, even when they're virtual. And we really rely on our industry partners to subsidize these. So I'd really encourage you all to listen to the next session, which is industry partnered introductions, which is being led by Dr. Geiger. And then also use that time to visit the sponsor booths. You can chat with colleagues within this unique platform, catch up. And I think Dr. Calkins said yesterday he was struggling to find DoorDash. You can use that DoorDash to get your lunch, so you don't have to leave and you can stay put and listen to the next important session. So with that, we'll move on, and thank you so much.